Nephrolithiasis affects about 12% of the population worldwide and has a high prevalence and recurrence rate. Our goal is to discuss multiple modern techniques that have been used at our institution to increase stone-free rate and potentially decrease operative time. The Cleopatra suction evacuation sheath consists of 5 different parts: the sheath, obturator, rubber cap, connection tubing, and stone collection bottle. At the end of the sheath, an oblique suction tube comes off at a 45-degree angle. It contains a negative aspiration port that can be used to control the degree of suction. The Cleopatra flexible ureteral suction sheath is a flexible ureteral access sheath that measures 10 French by 40 centimeters that can be advanced past the UPJ into the kidney and guided under direct visualization by advancing the sheath over a flexible ureteroscope. While treating stones, there is unimpeded suction of dust and small stone fragments around the scope into the sheath that are collected in the collection canister. When fragments too large for passive suction are generated, negative aspiration pressure can be activated by covering the pressure vent on the oblique tubing on the suction sheath. While doing that, the scope is simultaneously pulled back and stone fragments are drawn down the access sheath under direct visualization. This flexible ureteral access sheath allows the surgeon to achieve targeted suction to remove dust as it is being generated, improving visibility and decreasing stone burden that the patient will have to pass spontaneously. The negative aspiration eliminates the need for basketing and allows for multiple larger stone fragments to pass down the sheath simultaneously. Additionally, the ability to direct a suction sheath under visualization using retrograde access provides a novel method of addressing soft matrix stones that would be otherwise difficult to treat retrograde. This is more effective than syringe aspiration through the working channel of a flexible ureteroscope and less morbid than performing a PCNL for suction capabilities. We can see the same concept during a PCNL using the 16 French by 13 cm Cleopatra nephrostomy sheath. The benefits of this sheath are its size and flexibility. Its smaller diameter provides the surgeon with greater mobility within the collecting system and utilizes suction in calyces that may be more difficult to reach with a traditional PCNL suction lithotripter. The surgeon is also able to perform PCNLs through smaller access, i.e. mini PCNL, allowing for decreased postoperative complications such as bleeding and decreased patient morbidity. Lastly, the use of intraoperative CT scan during PCNL has been proven to increase stone-free rate, decrease the amount of planned reintervention, lower rate of urgent presentation with ureteral obstruction, lower total CT-based effective radiation dose, and decrease length of stay. Additionally, while obvious dense calcium-based stones can usually be picked up on fluoroscopy, uric acid-based residual fragments may be better detected using the CT. On this first C-arm image using the ZM-C-arm, there is a residual fragment that was picked up on the intraoperative CT. We were able to continue the PCNL and treat the stone, avoiding a second operation. The second C-arm shown is the GE-OEC. In our experience, this C-arm gives a better quality image even with metal artifact from the bed, but at the cost of a higher radiation dose to the patient when compared to the ZM C-arm. In conclusion, there are multiple new techniques that may improve stone-free rates, improve ergonomics, and decrease operative time for stone surgeries. Intraoperative CT scan has been shown to reduce postoperative complications and reinterventions after PCNL. However, more data is needed to assess different radiation exposures. Future studies are needed to establish clinical significance of these new technologies.